Good afternoon.
Good afternoon. Do you swear or affirm that the testimony you're about to give is true?
I do.
Thank you.
Good afternoon. My name is Tom Madejski. I'm the president of the Medical Society of the State of New York. I'm an internist who specializes in geriatric medicine and palliative care. One of my other professional hats is that of medical director for Orleans Hospice. In my experience, there are great disparities in access to and the quality of care at the end of life. It is an extremely complex issue with large variations in the wishes of patients, as you've heard this morning, and the application of care when patients approach the end of their natural lifespan or are faced with a terminal illness. First and foremost, I believe that we need to create an environment that eliminates the desire for a patient to contemplate ending their life due to fear of inadequate care at the end of life. As the recently elected president of MSNY, I have asked a number of our committees to examine how MSNY can help to improve the care of our patients at the end of their lives. Assembly Bill 2383A would permit a terminally ill patient to request medication from physicians to be self-administered for the purpose of hastening the patient's death. Until such time as the law changes, aid in dying or assisted suicide by a physician is still illegal in New York State. The New York Court of Appeals, September 7, 2017, Myers versus Schneiderman decision reaffirmed this. In 2017, the MSNY House of Delegates passed a resolution calling upon the Medical Society to conduct a membership survey to determine our members' attitudes on death and dying. This resolution also called upon the Medical Society's Bioethics Committee to develop the survey instrument. The MSNY Bioethics Committee, under the tutelage of its chair, Dr. Jeffrey Berger, Chief of the Division of Palliative Medicine and Director of Clinical Ethics at NYU Winthrop Hospital, began work immediately following that. The committee members took great care in the development of the survey questions to ensure that there would not be bias in the results. The survey questions resolved around individual physician experience with death and dying and patient requests for assistance. The questions also included whether physicians would prescribe a lethal dose if it were illegal to do so under New York State law, whether or not the activity was within or without the appropriate scope of physicians' medical practice, whether the activity, if legally permitted, would have any effect on trust of physicians, particularly within racial, ethnic minorities, and the disabled community. This work was recently completed, and on March 5th, the survey was sent by email to MSNY members. The survey period closed on Monday, March 19th, 2018. Most physicians who responded to the survey did not support a prescription for a lethal dose of medication for a terminally ill patient. A large majority indicated that such a measure could have a negative impact on health care among racial and ethnic minorities and physically disabled patients. Equally troubling were physician concerns that such a measure would have a significant negative impact on trust between physicians and patients. Our Bioethics Committee is currently analyzing the data related to the survey with an anticipated report to the MSNY Council in the near future. Our surveys are helpful in giving our leaders a general sense of the perspective of our membership with regard to how to best approach an issue. This is a very complicated and controversial issue within our membership, and you've heard some of our members testify already on both sides of the issue. There are passionate physicians on both sides who make well-reasoned arguments. MSNY's long-standing position against aid in dying is based upon the sacred principle that physicians are dedicated to healing and preserving life, not ending it. Based on the very preliminary survey results, MSNY does not anticipate changing its position on this matter anytime soon. In 2015, MSNY's Bioethics Committee recognized there was a need to update its policy on the issue and brought a resolution to the MSNY House of Delegates asking for a revision of the statement regarding physician-assisted suicide as a means of trying to balance the evolving views of the MSNY membership. Members of that House of Delegates agreed with revision to the statement, but definitively wanted the statement, physicians should not perform euthanasia or participate in assisted suicide, included in the policy. The policy in whole reads, patients with terminal illness uncommonly approach their physicians for assistance in dying, including assisted suicide and euthanasia. Their motivations are most often concerns of loss of autonomy, concerns of loss of dignity, and physical symptoms which are refractory and distressing. Despite shifts in favor of physician-assisted suicide as evidenced by its legality in an increasing number of states, physician-assisted suicide and euthanasia have not been part of the normative practice of modern medicine. Compelling arguments have not been made for medicine to change its footing and to incorporate the active shortening of life into the norms of medical practice. Although relief of suffering has always been a fundamental duty in medical practice, relief of suffering through shortening of life has not. Moreover, the social and societal implications of such a fundamental change cannot be fully contemplated. MSNI supports all appropriate efforts to promote patient autonomy, promote patient dignity, and to relieve suffering associated with severe and advanced diseases. Physicians should not perform euthanasia or participate in assisted suicide. MSNI will continue to examine the issue through our Bioethics Committee and our MSNI Council. MSNI is committed to work with physicians and groups on both sides of this difficult question to continue to improve the access to and quality of palliative care for all of our patients, particularly in their last days. I would like to share some personal experiences regarding the difficult circumstances to which this legislation could apply that I hope will provide additional nuanced information that will assist you in your deliberations. I've practiced geriatric medicine and palliative care for 25 years and agree that this is one of the most challenging questions for me personally and for us as a profession. I believe I am able to understand both sides of the issue and have had to deal directly with the question on a regular basis. In my practice, I have been able to have discussion with my patients and adjust their treatment to relieve their fears and suffering. Most physicians are deeply troubled by the potential abandonment of a patient by their physician at their time of greatest need of their physician's skill and caring. Although the proposed legislation requires 2 physicians to certify a patient, prognostication, as you heard in some earlier testimony, particularly with regards to time left before death, is one of our most difficult assessments. There's also a subset of patients admitted to hospice or who are otherwise felt to have a limited life expectancy who are misdiagnosed or have substantially less aggressive disease after optimizing their treatment. I have had patients under my care in hospice who legitimately could be certified as having a life expectancy of less than 6 months, who've lived up to 3 years. In the last year, I've had a new experience which I believe is related to societal change and attitudes toward the burden of life, not just on patients, but on the family that has to contribute to their care. I admitted a patient to a nursing home with moderate dementia, a probable lung cancer, and advanced lung disease. I did not have a pre-existing relationship with the patient or the family. After about a week at the nursing facility, the family requested hospice services, which were appropriate based on the patient's overall condition. I continued to treat the patient within hospice and optimized her medical regimen, and she stabilized. A few months passed, and one afternoon I received a somewhat angry call from a family member in Texas who wanted to know why I was keeping his mother alive. I explained that we were treating her with usual medical care and that treating her lung disease improved her comfort. That seemed to satisfy that child, but over the next month or so I had multiple contentious meetings with the family who basically wanted me to euthanize their mother. The patient was able to participate in decision-making initially, indicated she was comfortable and not in distress. As her dementia progressed, she was less able to make her needs known. I was left then to deal with her family member who had been designated as her healthcare proxy. With great difficulty, we were able to negotiate her care until she passed. The experience was extremely traumatic for my nursing staff and other caregivers who felt they were being coerced to over-medicate the lovely woman they had come to know in over 6 months. I'm still troubled by this case, and I've had another similar experience in the last year. And I'm sure similar scenarios occur countless times every day across New York in hospitals, nursing homes, and hospice. Thank you again for the opportunity to speak with you. I'm happy to answer questions.
Thank you. I just have, I think, just one question. Has the Medical Society considered current New York law and practice on palliative sedation, and is it considering recommending any change in the law on palliative sedation?
I'm not aware that it has been recently reconsidered. Part of that is looked at routinely, and I'm happy to have that re-looked at by our Bioethics Committee. We're in the process of reviewing the entire situation. I mean, right now, in an attempt to treat somebody who has intractable symptoms, we may end up using combinations of medications that will slightly hasten someone's death in an attempt to make them comfortable when their prognosis is as bad as it is.
Yeah,
So that's standard medical practice.
yeah, I'm certainly not